Okay, guys, in this lecture, we will be discussing about the salivary glands, their anatomy, physiology, as well as their pathology. Salivary glands are a group of compound exocrine glands, and they secrete saliva. Saliva is a complex fluid produced by the salivary glands. It forms a film of fluid coating the teeth and mucosa, thereby creating and regulating a healthy environment in the oral cavity. The parenchymal elements are derived from the oral epithelium and consist of terminal secretory units, which we call acini, leading into ducts that eventually open into the oral cavity. The connective tissue forms a capsule around the gland and extends into it, dividing groups of secretory units and ducts into the lobes and lobules. Blood and lymph vessels and nerves that supply the gland are contained within the connective tissue. The terminal secretory unit, irrespective of size and location, is made up of epithelial secretory cells. There are two types of secretory cells, serous and mucous cells. Serous mucus, along with the myoepithelial cells, are arranged in an acinus or multiple, we call acini, with a roughly spherical or tubular shape and a central limb. If we look into the histology of salivary glands, they share almost the similar type of histological structure. A secretory portion, which we call acini, then a web of arborized ducts that open into the buccal cavity, which release the, it is not releasing the saliva, it's autocorrection mistake. The parotid is a serous gland composed mainly of serous acinar cells, but it may contain accessory glandular tissue formed by mucinous acinar cells. Therefore, saliva secreted by the parotid is serous as well as watery. Each serous acinus is surrounded by myoepithelial cells that contract to help expel the secretions from the acini. Well, there is an extracellular matrix, stromal cells, immune cells, myofibroblasts, and nerves are found in the periphery of these acini. If we look at the schematic diagram, this is the typical salivary gland. There is a serous acinus or acini, then the serous acini in cross-section can be seen, then the serous demilunes in cross-section, mucus acinus, then mucus acinus in cross-section, then there are intercalated ducts. Then there are intercalated ducts in cross-section, striated ducts in cross-section, and finally the terminal excretory ducts. Differences between serous and mucus acini. There is no need to go into the detail from the Irish exam point of view about the light microscopy and electron microscopy, because we do not have questions like that. But still, I will provide you with these charts. If you want to go through it, you can. Myoepithelial cells. Myoepithelial cells are closely related to the secretory and intercalated duct cells. There are stellate or spider-like with a flattened nucleus, scanty perinuclear cytoplasm, and long branching processes that embrace the secretory and duct cells. Their appearance is reminiscent of a basket cradling the secretory unit. Hence the term we call these basket cells. Myoepithelial cells are similar to smooth muscle cells but are derived from the epithelium. Myoepithelial cells we are discussing. The precise functional role of myoepithelial cells in salivary secretion is not very clear. However, the following structural details clearly indicate its contractile function. The structure of the myoepithelial cells is similar to that of the smooth muscles. Immunofluorescent studies indicate presence of myosin, actin, and related proteins. After appropriate stimulation, the measurement of the ductal pressure of myoepithelial cell indicates a contractile process. Cinemomicrography or cinemicrography of individual secretory unit stimulated to secrete in vivo reveal a regular pulsatile movement of the entire unit, pulsating movement. The functions related to myoepithelial cells indicate clearly that myoepithelial cells actively can accelerate the initial outflow of saliva from the acini. Reduced luminal volume, the intercalated ducts may shorten and widen the ducts, helping to maintain their patency. They contribute to secretory pressure in the acini or in the ducts, support the underlying parenchyma, and reduce the back permeation of the fluid. They help salivary flow to overcome increase in peripheral resistance of the ducts. Ducts of the salivary glands. The ductal system of the salivary glands consists of hollow tubes connected initially with the acinus and then with other ducts as the ducts progressively grow larger from the inner to the outer portion of the gland. Each type of duct is lined by different types of epithelium depending on its location in the gland. The ductal system is not just a pipeline or conduit for the passageway for the saliva, it also actively participates in the production of modification of saliva. In the production as well as in the modification. In a salivary gland, the smallest ducts are the intercalated ducts. They are connecting the terminal secretory units to the next larger duct, which are the striated ducts. In the interlobular tissue, the ducts continue to join one another, increasing in size until the final excretory duct is formed. Differences among intercalated, striated, and excretory ducts. Question could be asked about it. So let's just have a look on it. Location, then cell morphology, size comparison, lumen, cell details, plasma, basal plasma membrane, solute concentration, electron microscopy, and the function of these ducts. Location of the intercalated duct. Intralobular. Striated, again intralobular, whereas excretory ducts are interlobular. So wherever there is an exception, expect a question. Remember this formula. Cell morphology, single layer of low cuboidal cells intercalated, striated, single layer of tall columnar cells, and excretory ducts, pseudo-stratified means they are not stratified means if there is single cell layer, it is non-stratified. If there are more than one layer of cells, we call it stratified. But if it is actually not stratified, gives the resemblance to stratified, we call it pseudo-stratified. Pseudo-stratified columnar means tall cells. Epithelium to stratified squamous. From there to there, anything will be there. Smallest in diameter are the intercalated ducts. Bigger than the intercalated are striated, and largest in diameter are the excretory cells. Size comparison of the intercalated ducts is smaller than secretory end pieces, striated larger than the secretory end pieces, and excretory are larger than the striated ducts. Lumen of the intercalated greater than secretory end pieces of lumen of the intercalated, then striated greater than the secretory end pieces, and finally the excretory greater than the secretory end pieces. Cell details of intercalated, centrally located nuclei surrounded by scant cytoplasm, very small amount of cytoplasm in intercalated, and nuclei are centrally located. In striated, again, the nucleus is having a central place, but cytoplasm is in abundance. And in excretory, different types of cells and nuclei. It is not like one type. There are various types of cells as well as their nuclei are present. Basal plasma membrane of the intercalated, no indentation. In the striated infoldings of basal plasma membrane partitioning basal cytoplasm, and there is no indentation in excretory. This is very important point, solute concentration. In the intercalated, it will be isotonic or hypertonic, anything can happen. But in striated, it is hypotonic, as well as in excretory, it is hypotonic. Solute concentration we have discussed. Then electron microscopic scopy, there is no question, so no need to go into that detail. Function of the intercalated: contribute to macromolecular components like lysozymes and lactoferrin. The striated, they are site for electrolyte reabsorption and active transport. Usually question comes on that where the bicarbonate are going to be added into the saliva, and that is in the intercalated one. Striated one. Site for the electrolyte reabsorption and active transport. Remember this thing. Bicarbonate ions, they are going to be added to the saliva in the striated. Then comes the excretory, no modification occurs. Other cell types present, undifferentiated cells that can undergo differentiation. This is the site for the stem cells, intercalated. Then striated, none. And dendritic cells, APCs, and lymphocytes and macrophages are present in the excretory one. Myoepithelial cells, they are present at the periphery of the duct, and they are absent in rest of the two ducts. Salivary glands, they are actually three major pairs of salivary glands: two parotid, two submandibular, and two sublingual. There are multiple minor salivary glands, and they are scattered throughout the oral cavity. Saliva. Saliva is first produced in the acinar lumen and then altered into a mixture of electrolytes and macromolecules as it is actively transported through the ducts. The saliva is hypotonic when it reaches the mouth, but salivary flow rates can influence the electrolyte composition. In addition to electrolytes, saliva also contains much mucin and the digestive enzymes. The most important enzyme is amylase. Question comes on this, which initiates the digestion of carbohydrates. Well, functions of saliva. Functions and the components. Which components are responsible for that function? Protection and lubrication from the mucin, then the proline-rich proteins and water. Antimicrobial action, lysozyme, lactoferrin, lactoperoxidases, mucins, cystins, histidines, IgM, then PRP, and immunoglobulin A. Mucosal integrity by the mucins, electrolytes, water, dilution and cleansing by water, buffering capacity and remineralization by bicarbonate, phosphate, calcium, statin, and proline-rich anionic proteins and fluoride. Deglutination by water and mucins, digestion by amylase, lipase, taste by water and lipocalins. Phonation by water and mucin, excretion through the water. Composition: 99% water, 1% inorganic ions. Secretory proteins, main electrolytes are sodium, potassium, calcium, chloride, bicarbonate, and phosphates. Organic substances: amylase, ribonuclease, callicarin, esterases, nystatin, cystatin, peroxidase, lysozyme, then lactoferrin, acid phosphatase, mucin, proline-rich proteins. Other organic substances are clotting factors, amino acids, urea, glucose, lipids, and hormones. Immunoglobulins like IgA, IgG, and IgM are also present. Mixed saliva, which we call the whole saliva, contains secreted saliva and desquamated, again, important point, desquamated oral epithelial cells are also present. Other than that, microorganisms, their byproducts, leukocytes, food debris, and gingival crevice fluid is also present in it. Nerve supply and nervous control of the salivary secretion. Saliva production is increased when the blood flow to the salivary glands is stimulated by parasympathetic activity. Remember this, not sympathetic, but parasympathetic activity. Easy way to remember this, when we get scared of something, dry mouth. So in case of emergency, there is dry mouth. And emergency, we have our sympathetic. Then again, easy way to remember, whenever someone is in stress, you want sympathy for them. That person would be looking for sympathy. That is why sympathetic. Just remember this, mnemonic, easy way to remember. Well, salivary flow is stimulated by parasympathetic activity, and there will be an increased blood flow towards the salivary glands. Then saliva production occurs. Sympathetic and parasympathetic fibers innervate the parotid gland. Sympathetic innervation causes vasoconstriction, and parasympathetic innervation from the glossopharyngeal nerve produces the secretion of saliva. Remember that though facial nerve, it passes through the parotid gland, but it does not innervate the parotid gland in any ways. Saliva secretion that is dependent upon the glossopharyngeal nerve. The parasympathetic fibers originate in the inferior salivatory nucleus in the medulla and travel through the jugular foramen to the inferior ganglion. A small branch of the glossopharyngeal nerve, which we call the tympanic or Jacobson nerve, it forms the tympanic plexus within the middle ear. These preganglionic fibers become the lesser petrosal nerve and course. Less question came, one of the question on the lesser petrosal nerve, and course through the middle cranial fossa before exiting through the foramen ovale. So foramen ovale, two important anatomical structures are coming out of it. One is mandibular branch of the trigeminal, and second one is lesser petrosal. Question came on that as well. Remember this thing. These are the two important structures. So lesser petrosal nerve and course through the middle cranial fossa before exiting through the foramen ovale. They synapse in the otic ganglion, and the postganglionic parasympathetic fibers join the auriculotemporal nerve to innervate the parotid gland and to secrete the saliva. The neurotransmitters acetylcholine and norepinephrine act within the parotid. Acetylcholine binds muscarinic receptors to stimulate the acinar activity and ductal transport. It also uses second messenger activity producing inositol triphosphate, leading to increased calcium concentration within these cells. As a result, salivary secretion increases. Norepinephrine transmits sympathetic nervous impulses via postganglionic sympathetic fibers to the salivary glands. Sympathetic outflow thickens the saliva. Norepinephrine binds beta-adrenergic receptors activity, the adenylate cyclase second messenger system, producing CAMP, phosphorylating proteins, and the activating enzymes. The facial nerve courses through the Parotid gland providing motor supply to the muscles of facial expression, but does not provide innervation to the gland. I have already mentioned about that. A branch of facial nerve, cauda tympani, along with the lingual nerve, supplies the parasympathetic fibers of other two salivary glands, that is submandibular and sublingual glands. So far, so good. Everybody is okay. Yes, no, maybe. Any ambiguity, any question on these things, please ask. Okay, great. Parotid gland. Parotid is the largest of the three paired major salivary glands, including the submandibular and sublingual glands. It is located in the retromandibular fossa, space mainly occupied by this gland. It is bordered superiorly. Question comes on the boundaries. Bordered superiorly by the zygomatic arch, anteriorly by the masseter muscle, posteriorly by the sternocleidomastoid muscle. However, the superficial lobe extends anteriorly, covering the mandibular ramus and the posterior area of the masseter muscle. Parotid gland produces serous saliva, which means it will be more watery and thin. It has the protein amylase that helps begin the process of starch or glucose digestion. Amylase is responsible for starch digestion. While we are not eating the parotid glands, each of the two, they contribute to 10% of saliva in the mouth, but when stimulated by eating the saliva, each parotid gland accounts for 25% of the saliva present in our oral cavity. Well, usually we think that accessory glands are the minor salivary glands. That is not correct. Minor salivary glands, they are called minor salivary glands, and we get confusion over here, and that's why we answer the question wrongly. Accessory gland is basically an additional part of the parotid gland, but present only in 21% of the population. This is the accessory parotid gland. Remember this thing. Thank you. Yeah, sure. So it is located approximately 6 millimeter anterior to the main parotid gland between the skin and the masseter muscle, along an imaginary line that extends from the tragus to a point midway between the ala of the nose and the vermilion border of the lip, which we call ala-tragal line. It has a secondary duct emptying into the Stenson's duct, the accessory parotid gland, little known and seldom mentioned in the literature. Important structures that run through the parotid gland. Questions come on this. Branches of the facial nerve, terminal branch of the external carotid artery that divided into maxillary and superficial temporal artery. The retromandibular vein, that is the posterior facial, and intraparotid lymph nodes. Just a minute, guys.
Hello, doctor. You are not audible. Dr. Nagman, you are muted.
Oh, sorry. Are you good now?
Yes, doctor. Yeah. We can hear you now.
Are you good now? Okay, great. Sorry for that.
Yes, doctor.
So I was telling you about the intraparotid lymph nodes. We have discussed about it. Then we have this schematic diagram of the cross section, and we can see the parotid gland and the those anatomic structures which are passing through it. Parotid duct. Name is Stenson's duct. It is 5 centimeter long. It opens opposite to the second upper molar tooth and is the area of calculus accumulation. Calculus most commonly forms in the area where salivary gland ducts they are opening, like in the upper buccal area, especially close to the second molar on the buccal side, and lower incisors on the lingual side, where the submandibular and the sublingual ducts they are opening. Is it clear to everyone? Yes, no, maybe.
Yes, doctor.
Good. Blood supply of parotid gland. The external carotid artery provides blood supply to the parotid. External carotid, not the internal. It bifurcates into two terminal branches, the superficial temporal artery and the maxillary artery. Superficial temporal artery gives off the transverse facial artery, which runs anteriorly between the zygoma and parotid duct and supplies the parotid duct, parotid gland, and masseter muscle. The maxillary artery supplies the infratemporal fossa and the pterygopalatine fossa after exiting the medial portion of the parotid. The retromandibular vein, which forms from the confluence of the superficial temporal and maxillary veins, they provide venous outflow for the parotid. It courses deep to the facial nerve and it may exhibit variable anatomy before joining the external jugular vein. Parotid gland and the surgical considerations, questions, they were appearing in this exam based on this parotidectomy and what complications can occur. The parotid gland is the location of 80% of salivary tumors. The most common primary parotid tumor is pleomorphic adenoma. The management of neoplasia of the parotid typically includes surgical resection. The facial nerve courses through the glandular substance of the parotid gland. Identifying this nerve is crucial when performing surgical procedures in the gland to prevent the injuries. Bony and soft tissue landmarks commonly used to identify the facial nerve trunk include the cartilaginous tragal pointer, the tympanomastoid suture, the posterior valley of the digastric muscle, the styloid process, and the retromandibular vein. That's how we identify the facial nerve. There is a tumor inside. If we do not identify it, isolate it, then definitely we are going to injure it. This is the trunk and the bifurcation of the trunk we can see easily. Then when it further comes forward, then another bifurcation is visible. Parotid gland and parotidectomy. Facial nerve injury is the most common complication of parotid surgery as the two structures are intimately related to each other. This is because of the fact that during embryogenesis, the parotid gland entraps mesenchymal structures which later develop into the facial nerve. Postoperative facial nerve weakness can be temporary or permanent. The temporary weakness is much more common and incidence is between 10 to 50% of the parotidectomies. The cause of temporary weakness is neuropraxia, which results from a combination of trauma while dissecting the right on the nerve and traction injury to the nerve itself, heat injury, secondary to use of electrocautery and prolonged operating time. The incidence of permanent facial nerve injury is generally reported just 0.5%. In a study, question is there in the exam, one of these exams, in a study, 90% of cases of facial nerve injury involved the marginal mandibular nerve. Which branch, they ask, and that is marginal mandibular nerve, and 54% cases they showed zygomatic branch. So far so good, everybody is okay, yes, no, maybe. Submandibular gland. It is a paired gland and lies below the mandible bilaterally. It has two lobes, superficial and deep. Wharton's duct drain. Keep in mind there is a difference between Wharton's tumor and Wharton duct. It is Wharton duct. Wharton's duct drain submandibular gland that opens into anterior floor of mouth. Anatomical relationship to lingual nerve, hypoglossal nerve, anterior facial vein, facial artery, marginal mandibular branch of the facial nerve. Blood supply of the submandibular gland. The submandibular gland is supplied by the submental artery, which is a branch of facial artery, and sublingual artery, which is a branch of lingual artery. Its venous drainage is by two vessels, the facial vein, which empties directly into the internal jugular vein, and sublingual vein, which drains into the lingual vein. Then that drains into the internal jugular vein. Sublingual gland. It is also a paired lingual gland. Lies on the superior surface of the mylohyoid muscle bilaterally and are separated from the oral cavity by a thin layer of mucosa. The major ducts of the sublingual glands, they are known as Bartholin's ducts. There are also smaller ducts, which we call ravenous ducts, that release the secretion beneath the tongue onto the floor of the mouth. Smaller ducts. Multiple. Blood supply of the sublingual gland. Blood supply is via the sublingual and submental arteries, which arise from the lingual and facial arteries respectively. Both are the branches of the external carotid artery. Venous drainage is through the sublingual and submental veins, which drain into the lingual and facial veins respectively, which then drain into the internal jugular vein. Then comes the minor salivary glands. At an average, 450 minor salivary glands are present in the oral cavity, but they could be up to 600 to 1000 even in some of the cases. They are distributed in the mucosa of the lips, cheeks, palate, floor of mouth, and retromolar area. They also appear in the oropharynx, larynx, and trachea. Over here, differences between major and minor salivary glands, size, then number, occurrence, location, contribution to whole saliva, capsule, excretory duct size, secretion, viscosity, and secretion contents. So size of the major, of course, larger, minor, smaller. Number, 3 in number, hence named individually on both the sides. They are overall in the oral cavity. Some of the authors, they say 450, others say 600 to 1000 in oral cavity and oropharynx, hence named as a group according to their location. They are not named individually. Well, occurrence of the major salivary glands bilaterally, whereas minor salivary glands are diffusely spread. Location of major salivary glands, they are not present intraorally. They are always extraorally, but ducts are opening intraorally. Whereas minor salivary glands, they are present intraorally. Contribution to whole saliva, major salivary glands 90 to 95%, minor salivary glands 5 to 10% more secretion during the sleep. Well, capsule is present in major salivary glands. They are encapsulated, whereas minor salivary glands, they do not have capsule. Excretory duct, single main excretory duct to the major salivary glands other than sublingual. Sublingual is having two different types of salivary ducts. Whereas minor salivary glands, they have multiple excretory ducts. Excretory duct size for major salivary glands, long excretory ducts, minor salivary glands, short excretory ducts. Secretion of major salivary glands mostly mixed except the parotid, which is purely serous. Whereas minor salivary glands, they are having mucus or mixed except one Ebner's gland, which are completely serous. One Ebner question can be asked on that. As I always say, where there is an exception, expect a question. Secretion and viscosity of the saliva. Major salivary glands thin and watery, whereas minor salivary glands thick and mucus. Secretion contents of the major salivary glands rich in enzymes, mucus, and proteins. Minor salivary glands, proteins, important role in innate immunity is suggested. Disorders of minor and sublingual salivary gland. These are the classification according to Ragusea. Reactive lesions, mucus extravasation phenomenon, mucus retention cyst, maxillary sinus mucocele, then necrotizing silometaplasia, adenomatoid hyperplasia, then infectious silodenitis, mumps, cytomegaloviral silodenitis, bacterial silodenitis, sarcoidosis, metabolic conditions, Sjogren syndrome, salivary lymphoepithelial lesion, scleroderma, xerostomia, taste disturbances, and halitosis. Benign neoplasm, mixed tumor, pleomorphic adenomas, basal cell adenomas. Then canalicular adenoma, myoepithelioma, oncocytic tumors, then sebaceous adenoma, ductal papilloma, malignant neoplasm, mucoepidermoid carcinoma, polymorphous low-grade adenocarcinoma, adenoid cystic carcinoma, clear cell carcinoma, acinic cell carcinoma, adenocarcinoma, not otherwise specified. Rare tumors, carcinoma, for example, like it is coming out of the mixed parotid tumor. Previously, it was mixed parotid tumor transformed into carcinoma. Malignant mixed tumor, metastasizing mixed tumor. Then epimyothelial carcinoma, salivary duct carcinoma, basal cell adenocarcinoma, memory analog secretory carcinoma, and squamous cell carcinoma. Cysts. They could be mucoceles, extravasation cysts resulting from trauma to overlying mucosa. Mucus retention cysts in the floor of the mouth due to obstruction. Ranula is the extravasation cyst that arises from the sublingual gland. Mucus extravasation phenomena. What happens actually? This is extravasation type. This is the retention type. Two different phenomena. The cause of mucus extravasation phenomena is traumatic severance of a salivary gland excretory duct, which results in the escape of mucus or extravasation into the surrounding connective tissue. There is an inflammatory reaction of neutrophils. Later, there is an accumulation of the macrophages. Granulation tissue forms a wall around the mucin pool, and the associated salivary gland undergoes inflammatory change. Scarring occurs in and around the gland. Mucocele. The lower lip is the most common site of mucus extravasation phenomena, but other sites subjected to trauma may be involved, including the buccal mucosa, anterior ventral surface of the tongue, location of the mixed serous and mucous glands of Blandin-Noon, floor of the mouth, and retromolar area. Lesions are uncommonly found in other intraoral regions where salivary glands are located, probably because of lower susceptibility to trauma. Mucoceles of the upper lip are very uncommon, a site where salivary gland tumors are more likely to occur. Adolescents and children are more commonly affected as compared to adults. Plunging ranula. It is a rare form of mucus retention cyst which arises from the both sublingual and submandibular glands. The mucus collects around the gland and penetrates the mylohyoid diaphragm to enter the neck. Here we can see the patient presented with the dumbbell-shaped swelling, soft, fluctuant, and painless. Usually question is being asked that in case of plunging ranula, which glands are involved? So we know that both of them. And what is the shape? Dumbbell-shaped swelling. It is fluctuant and soft and is painless. Developmental problems, aberrant ectopic salivary gland tissues, that is a stiffness defect, they are visible on the radiograph. Like you are looking at the mandibular radiograph. This is the way it would be. And you see a small radiolucency here with the inferior border of the, after the ramus and after the angle of the mandible. This radiolucency is stiffness. At times it is continuous, and you see some radiolucencies. These are due to the inclusion of the salivary gland, and they are called stiffness defect. Previously, they were named as stiffness cysts, but now we call those stiffness defects. Then agenesis, they are not there, they are not produced. Duct atresia, congenital fistula formation. Acute infections, viral and bacterial. Viral, most common mumps. Other viral infections are extremely rare. Bacterial, most commonly due to obstruction. Treatment will be antimicrobials and or surgery. Infectious silhadenitis, mumps, cytomegaloviral silhadenitis, bacterial silhadenitis, sarcoidosis, Sjogren's syndrome, salivary lymphoepithelial lesion, and scleroderma. Mumps. Mumps is an infectious acute viral silhadenitis primarily affecting the parotid glands. The causative agent of infectious mumps is paramyxovirus. Transmission occurs by direct contact with salivary droplets with a 2 to 3 week incubation period preceding clinical symptoms. Clinical features include parotid area swelling, fever, chills, malaise, and headache, as well as preauricular pain. It could be unilateral, it could be bilateral. Orchitis or euphoritis may occur among the adults. That is why they say that if mumps, they are occurring in an adolescent or even an adult, then we have to be very, very careful, because chances would be that orchitis or euphoritis may occur. Treatment is bed rest and symptomatic. Xerostomia. Xerostomia or dry mouth is a common condition defined as an overall reduction in salivary output. There are many causes of this condition, and we could be asked about that in our exam. Medications like analgesics, opioids, anticholinergics, antihistamines, antidepressants, selective serotonin reuptake inhibitors or SSRIs, which are used in depression. Tricyclic and heterocyclic antidepressants as well, atypical antidepressants, antihypertensive agents, diuretics, muscle relaxants, and sedatives or anxiolytics. Autoimmune or systemic diseases, Sjogren's syndrome, primary biliary cirrhosis, then Wegener's granulomatosis, sarcoidosis, scleroderma. Other conditions may be due to the radiation therapy or in that area. Type 1 or type 2 diabetes, radioactive iodine treatment in case of thyroid problem, human immunodeficiency virus, acquired immunodeficiency syndrome or AIDS, and anxiety and depression. Management of xerostomia, palliation. Elimination of alcohol and caffeine consumption, elimination of alcohol-containing mouth rinses, gustatory salivary stimulation, sugarless candies or gum, moist sugar-free or complex carbohydrate foods, oral lubricants, carboxymethyl cellulose or hydroxymethyl cellulose-based products, other polymer-based rinses, then scrupulous oral hygiene. Prescription strategies. Cholinergic agonists can be prescribed, pilocarpine, cevimeline, and acupuncture. Usually question comes on pilocarpine, why we can prescribe it for xerostomia or dry mouth. Siluria. There will be excessive salivation and drooling causes some infections and drugs. Usually it is present in children who are mentally handicapped. Sorry for one additional N over here. Also among the people with cerebral palsy. Taste disturbances or dysgeusia. Taste or gustation relates to the perception of the 5 traditional elements: sweet, salty, sour, bitter, and umami, that is savory, and their relationship to each other. They form a flavor in combination which is derived from the collective sense of smell and trigeminal inputs of texture, temperature, and pungency over surfaces of the tongue, oral cavity, and nasal cavity. The complex relationships between these components may become distorted, leading to disturbances in taste, including hypogeusia, means blunted taste, ageusia, absence of taste, cacogeusia, unpleasant or obnoxious taste associated with familiar, previously acceptable foods, and dysgeusia, altered or incongruous taste, perception, or a persistent misinterpretation of the normal taste sensation. Alteration in taste can be minimal and only slightly bothersome to incapacitating, with possible result in depression and anorexia as secondary clinical events. Taste disturbances and their reasons. Diseases associated with taste disturbances: Bell's palsy, cancer, oral head and head and neck irradiation, candidiasis, thrush, diabetes mellitus with associated peripheral neuropathy, gingivitis, periodontitis, hypothyroidism, multiple sclerosis, Parkinson disease, then pernicious anemia, that is vitamin B12 related anemia, then renal failure, hemodialysis, Sjogren syndrome, upper respiratory disturbances and infection or influenza, and zinc deficiency. Drug classes and agents which are associated with taste disturbances: angiotensin converting enzymes or ACE inhibitors. So these are used for controlling the blood pressure. Calcium antagonists, again used for controlling the blood pressure. Diuretics, again used in hypertension or in cardiac problems. Antiarrhythmics, antithyroid agents, antidiabetics, antihistamines, antiasthmatics, antidepressants, antipsychotics, antineoplastic agents, then chelating agents, neuromuscular, anti-seizure drugs, nitroglycerin, and in case of opioids as well. Salivary gland neoplasms. 80% of the salivary gland tumor occur in the parotid, as we have already discussed, 10 to 15% in minor salivary glands, and 5 to 10% in the submandibular gland. 80% of the parotid tumor are benign. The most common is pleomorphic adenoma. 50% of the submandibular gland tumor are benign. 30% of the minor salivary gland tumors are benign. We are discussing about the salivary gland neoplasm. Tumors of minor and sublingual salivary glands are extremely rare. 90% are malignant. Most common site, upper lip, palate, and retromolar region. Pathogenesis. Reserve cell theory. Currently, the favored theory of salivary gland neoplasia states that salivary neoplasms, they arise from reserved or stem cells of the salivary duct system. For example, adenoid cystic carcinoma and acinic cell carcinoma arising from the intercalated. I told you that stem cells are in the intercalated duct. So intercalated duct reserve cell. The mucoepidermoid carcinoma, squamous cell carcinoma, and salivary duct carcinoma, they arise from excretory reserve cell. Multicellular theory of salivary gland neoplasia states that salivary neoplasms arise from already differentiated cells along the salivary gland unit. For example, squamous cell carcinoma arises from the excretory duct epithelium, and acinic cell carcinoma, it arises from the acinar cells. Most common benign tumor of the parotid, pleomorphic adenoma. Benign mixed tumor, Warthin's tumor, difference between the Warthin's duct and Warthin tumor. Warthin tumor is in parotid. Warthin duct is in submandibular gland. Remember that. Papillary cyst adenoma, lymphomatosome, then monomorphic adenoma, basal cell adenoma, canalicular adenomas, then oncocytomas and myoepitheliomas, granular cell tumor, and hemangiomas. Pleomorphic adenoma, it is benign tumor. Mixed parotid tumor is easily the most common salivary neoplasm. It accounts for 50 to 77% of the parotid tumors, 53% to 72% of the submandibular, and 33 to 41% of the minor gland tumors. Pleomorphic adenomas are derived from a mixture of ductal and myoepithelial elements. A remarkable microscopic diversity can exist from one tumor to the next, as well as in different areas of the same tumor. The terms pleomorphic adenoma and mixed tumor both represent attempts to describe this tumor's unusual histopathologic features, but neither term is entirely accurate. The pleomorphic adenoma is typically a well-circumscribed encapsulated tumor. However, the capsule may be incomplete or show infiltration by the tumor cells. This lack of complete encapsulation is more common for minor gland tumors, especially along the superficial aspect of palatal tumors beneath the epithelial surface. Tumor is composed of a mixture of glandular epithelium and myoepithelial cells within a mesenchyme-like background. Pleomorphic adenomas are best treated by surgical excision in toto. Always remove completely, especially if it is major salivary gland because it is encapsulated. For lesions in the superficial lobe of the parotid gland, superficial parotidectomy with identification and preservation of the facial nerve is recommended. Local enucleation should be avoided because the entire tumor may not be removed or the capsule may be violated, resulting in seeding of the tumor bed. Good prognosis with more than 95% cure rate. Malignant degeneration is a potential complication resulting in carcinoma, pleomorphic adenoma, that is 3% to 4% cases only. Most common malignant neoplasm of the parotid gland, that is mucoepidermoid carcinoma. Usually question comes on that. Which one is the most common malignant? It is mucoepidermoid carcinoma, 40%. It can high, intermediate, and low-grade based on the clinical behavior and the tumor differentiation, which is related to the percentage of mucinous to epidermoid cell. Then second one is adenoid cystic carcinoma, 10% only. Adenoid cystic carcinoma are unique among the salivary gland tumors because of their indolent and protracted clinical course, characterized by preneural spread, including escape lesions. In this disease, thus specific survival continues to decline for more than 20 years after initial treatment. Then comes acinic cell carcinoma, 10 to 15%. It is considered as a low-grade tumor. Malignant mixed tumor, 7%. It is considered a high-grade malignancy. Then polymorphous low-grade adenocarcinoma, 10%. It is a low-grade variant of adenocarcinoma. Adenocarcinoma, 10%. It is a high-grade with poor prognosis. And squamous cell carcinoma, only 4%. Again, a high-grade, more common among the elderly people, and can be confused with high-grade mucoepidermoid carcinoma. The malignant parotid tumor can be classified into high-grade, aggressive behavior, local invasion, and lymph node metastasis, high-grade mucoepidermoid carcinoma, adenoid cystic carcinoma, carcinoma X pleomorphic adenoma, adenocarcinoma, squamous cell carcinoma, and undifferentiated carcinoma. Then low-grade malignancy, low-grade mucoepidermoid carcinoma, then polymorphous low-grade adenocarcinoma, acinic cell carcinoma, low-grade adenocarcinoma, and basal cell carcinoma. Then comes the intermediate grade. Intermediate grade mucoepidermoid carcinoma, intermediate grade adenocarcinoma, and oncocytic carcinoma. How we evaluate? History is important. Important points in the history: parotid mass, its duration, rate of the growth, and presence of the pain. Then facial paralysis, if it is present or not. Because if the facial paralysis is there and the growth, it appears fixed to the skin, that is definitely a malignancy. Then check for the cervical lymphadenopathies, eyes and joint symptoms, and history of exposure to the radiation. Then examine size of the mass, skin fixation, cervical lymphadenopathies, and facial nerve functions. Investigations, you can go for the CT scan, MRIs. They are both effective modalities for imaging the size, the local and regional extension of the primary tumor, and the neck metastasis. CT salography, it is replaced now by high-resolution contrasted CT and MRIs. Then fine needle aspiration. So that can also be done The accuracy is around 90%, depend on the technique of aspirate and the cytopathologist. Then superficial parotidectomy, it is considered as diagnostic and the therapeutic for most of the benign tumors. Skin flap necrosis. These are the post-operative complications. Hematoma, salivary fistula, and siloceles. It presents as an opening in the suture line below the lobule of the ear. Facial nerve paralysis, which could be temporarily 5 to 10% of the patients, permanent less than 2%, and numbness of the ear due to injury of great auricular nerve. Then xerostomia, not common in the superficial parotidectomy, 30% of the salivary producing tissue. Fraze syndrome is also a complication. That is gustatory sweating syndrome. Person is eating and they are sweating. Incidence in 50% of the patients. Etiology, post-operative growth of the interrupted preganglionic parasympathetic nerve branches to the parotid into the more superficial sweat glands. The diagnosis is usually made from the history but can be confirmed by the starch iodine test. Fraze syndrome is a rare neurological disorder that causes a person to sweat excessively while eating. Most commonly occurs as a complication of surgery involving the parotid gland. It may also occur following neck dissection, facelift procedures, or trauma to the area near the parotid gland. Symptoms usually develop within several months of the procedure or trauma, but may develop several years later as well. The main symptoms include flushing and excessive sweating, hyperhidrosis. On the cheek, temple, or behind the ear when eating or thinking about the food, we call it gustatory sweating. Some people with Fraze syndrome may experience a burning sensation, itching, or pain around the affected area. Symptoms are usually mild but can be severe, causing significant discomfort or social anxiety. Fraze syndrome is thought to be caused by damage to both the nerves that regulate the sweat glands and the nerves that regulate the parotid glands. It is believed that damaged nerves regrow abnormally and connect to the wrong glands. Fraze syndrome is diagnosed based on the medical history, for example, a history of surgery or trauma, and symptoms. The diagnosis can be confirmed with a test called the Miner's starch iodine test. So over here, we are done with our today's second lecture as well.